I decided to focus my presentation on surgical treatment of ROP. Okay? So we just heard that ROP is one of the most common causes of vision loss in childhood and can lead to blindness. It is a blinding disorder that affects premature infants weighing 1,500 grams and less and born between 31 weeks of gestation. The smaller is the baby at the birth, the higher is the chance to developing ROP. About pathophysiology, we have two phases. First, a vascular phase due to the decrease of VEGF that determines a chronic ischemia, and then we have a second proliferative phases due to the release of hypoxia inducing factor 1 that determines again the increase of VEGF with vasodilation and angiogenesis. So we classify ROP in zones a stage. Zone 1, twice the distance from macula to optic nerve centered at the optic nerve. Zone 2, from the edge of zone 1 to the nasal part of the aura. Zone 3, the remaining temporal periphery. Then we have 5 stages. Stage 1, when we have a demarcation line. Stage 2, when the demarcation line becomes a ridge. Stage 3, when we have the proliferation from the ridge. Stage 4, when we have a focal retinal detachment. And stage 5, when we have a total retinal detachment. So the first 3 stages, stage 1, 2, and 3, we can treat medically, as we just heard, with the laser therapy, cryotherapy, or anti-VEGF. Then stage 4 and 5 are our surgical stages. So before starting to talk about surgery, we have to point out some anatomical difference of the adult eye and the newborn eye. So the axial length of the newborn eye is 75% of the adult eye. The posterior segment volume is 20% of the adult eye, while the anterior segment volume is 80%. So we have a newborn eye with a relative big anterior segment volume compared to the posterior segment volume. This is important when we have to start vitrectomy to know how to apply the trocar. So in a child from 0 to 6 months, we will apply the trocar at 1.5 millimeters from the limbus. From 6 to 12 months at 2 millimeters from the limbus. From 1 to 2 years at 2.5 millimeters from the limbus. From 2 to 3 years at 3 millimeters from the limbus. After 3 years, we can consider the eye like an adult eye and apply the trocar at 3.5 millimeters. So some general consideration, as I just said, we have to always center more anterior in a newborn eye. Then we can find a retina larger than RPE area with some folds that can be radial or circumferential. About the vitreous, we can have vitreoschisis. Often we find some sheets of liquid and solid vitreous, and it's very important in stage 5 ROP, don't make any breaks during the surgery, otherwise we will have 100% failure of the surgery and the eye will end up with no light perception. So we can have different vectors of traction. We can have a ridge to the posterior lens surface. We can have a ridge to the peripheral retinal wall. We can have a ridge to the ridge, a ridge to the disc. So some surgical scenarios, we have a stage, we can have a stage for A with the focal retinal detachment and not involving the macula. When we have just a small traction, so we can decide to do a minimal surgery, a transvitreal surgery just to remove the traction, or we can decide to wait and don't perform surgery because in some cases the traction can be resolved. Then we have a stage 4B when we have a focal retinal detachment but involving the macula with the tractional membrane, so we need to do membrane peeling. Then we can have a stage 5 where there is not a clear vision of the tractional retinal detachment that we are facing. And then we have this crunch that occurs after treatment with the anti-VEGF, and is a circumferential tractional retinal detachment. This is the reason why we don't prefer treat ROP cases with anti-VEGF. So in ROP stage 4A and B, the goal is to minimize the retinal distortion to prevent a total retinal detachment. The timing of the surgery depends on the configuration. We can, in stage 4A, we can do a minimal surgery, as I just said, or if we need to do membrane peeling, we prefer to wait until the vascular inactivity, approximately around 48 to 52 post-menstrual age. The visual outcome goal depends on the severity. We have a very high rate of success in KCASH with the lens sparing. In stage 5, this is the presentation with the retrolental plaque. A corneal opacity is not predictable which kind of tractional retinal detachment we have. So in stage 5, if we have a funnel retinal detachment open anteriorly and open posteriorly, or open anteriorly and narrow posteriorly, we can do the lens sparing. But if we have a funnel retinal detachment narrow anteriorly and open posteriorly, or narrow anteriorly and posteriorly, we need to do lensectomy in order to remove the anterior membrane. So the anatomical goal in stage 5 is the partial or total reattachment of the retina. It's very important to maintaining the light perception and to maintaining the connection between the brain and the eye. Most of the cases requires two-stage surgery. In the first stage, we do a limbal approach lensectomy with a total capsulectomy, anterior hyaloid dissection, and we finish the surgery with the fluid viscoelastic exchange. The second stage, after 3 months, to allow the retina to settle back and to have a better view for the membrane peeling. This is a small video that shows the first stage of the surgery with the limbal approach lensectomy and total capsulectomy. As we can see, there is no view of the fundus, so we need really to remove the lens and to open the capsula. Okay, so In most of the 5-stage ROP, we need to perform a B-scan to understand the kind of retinal detachment. This is an example of a 32 weeks premature. The B-scan, we can see a funnel retinal detachment, open anteriorly and narrow posteriorly. This is another example, 29 weeks premature, with the total retinal detachment closed anteriorly and posteriorly. So in conclusion, it's very important early treatment of ROP cases, have a strong screening program. That's why we started the INCAE-CASH telemedicine project. Stage 4A and B gives very good result with the lens sparing. Stage 5, the surgery is complex and functional results are limited, but it's mandatory to ensure an anatomical result and to give at least light perception to the newborn. Thank you.